So the synapse, super, super important, okay? The average size of the synaptic cleft, okay, cleft just means between, so you've got this side of the synapse, this side of the synapse. That cleft is 0.02 microns. Honestly, I don't even know how small that is. It's beyond microscopic. It's teensy, teensy tiny. But just imagine, everything hinges on a little protein neurotransmitter being dropped or expelled, vomited, if you will. I'll credit Dr. Andrew Huberman for that term, from one side of the cleft to the other. So the neurotransmitter gets pumped out on one side, hits the other side, and remember, this is dendrite, right, to dendrite, or axon to dendrite to cell body. You have to have an adequate stimulus to trigger that spike in membrane potential to trigger the electrical charge. That is your threshold. So you either have to have enough of the neurotransmitter hit something, enough of a volt hit something, enough of a mechanical change hit something. Something has to stimulate that, right? So like, let's say the world's tiniest feather touched me. That might not be enough to tell the receptors in my fingertips that something has changed and then tell my brain I just felt something. Versus, if I whacked my finger with a hammer putting a nail in, obviously that's going to be enough of a stimulus. So the threshold is everything in pain. So there's subthreshold, so you can make it so the nerve will fire with very little change in membrane potential. You can make it so it'll fire with a much higher change in membrane potential. So that's how you can modify pain signals, or one way you can modify them. The other way is to change the number of neurotransmitters passed from the synapse, either way. And then also, the body has this amazing recycling system. Again, why sleep is so important, to clean everything up. But each of the neurotransmitters that are released are reuptook or reuptaked. So there are reuptake inhibitors. A lot of the antidepressants are serotonin reuptake inhibitors, SSRIs. And that's because they block the serotonin that's been released across the synapse from being recycled, which basically modulates how the signals work in the brain. And neurotransmitters, they're the same, whether it's depression or pain or excitement or rage or thinking. There's only so many neurotransmitters. They're all the same. That's why a lot of times we can treat pain, believe it or not, using an antidepressant medication. It's pretty cool because it's the same neurotransmitters. Anyway, once you meet that threshold, you have an action potential. It is all or nothing. There's no half-size action potentials. There's no double action potentials. You either meet that threshold or you don't. So when the action potential reaches the terminal bud, so that's the synapse, right? So the synapse from nerve A is the terminal bud. Calcium rushes in, okay? So there's your other important mineral for communication. We've talked about this before. Calcium is extremely important for cellular communication. Calcium changes a volt, receptors open, little balls filled with neurotransmitters open from that voltage coming in, and then the neurotransmitters are released. They cross the synaptic cleft, they bind receptors on the other side, more channels open, the positivity, negativity is changed, you have an action potential. So these receptors in synaptic clefts are very, very important. I'll give you an example. One of the ways that Botox works is it stops the reuptake of acetylcholine at this cleft. Acetylcholine is extremely important for motor function, for muscles to work. So if you can stop the acetylcholine from triggering action potentials, you've effectively stopped a muscle from working. And so that's how Botox can stop wrinkles and stop spasticity in people with, spastic paralysis after a stroke or whatnot. Okay, let's go on. Okay, so here, that top picture is an actual electron micrograph. It's been colored, obviously, of a true synapse. I mean, it's just pretty magnificent how the body works. And if you think about it, it's all just three-dimensional, messy, with time and just explosions happening at the cellular level, just massive amounts of change and electrical charges. But you just have no idea this is going on all the time in your body, and the reason why you feel anything more or less pain. So the neurotransmitter binds the postsynaptic, so it's across the cleft, it binds the postsynaptic receptor. They change shape, that's what receptors do whenever they get a certain stimulus. So remember the pump, until the sodium gets it and the energy hits it, it's like this. Once the energy and sodium's in, it changes shape. So they change shape, triggers something to open, and then you meet your membrane threshold potential, you have your action potential. And then this just keeps going down the nerve. And it takes only about 0.5 to 4 milliseconds for these neurotransmitters to be recycled for the next signal. So this is just happening more rapid than I can ever hope to imagine. These are some of your neurotransmitters. You may have heard some of these terms. This isn't a full list, but glutamate, the most important excitatory neurotransmitter, so very important for pain. Glutamate gets things hyped up, hyper. It's like having a guitar string that's so tight when you hit it, it breaks. That's people with really high tension set nerves. They're probably in a hyperglutamate sort of a situation. PGE2 and PGI2, those are prostaglandins. You may have heard of prostaglandins. This is why ibuprofen works. Celebrex works. Steroids, it shuts down the prostaglandins, which don't stimulate the nerve, which doesn't let you have a painful action potential. So on and so forth, all the way down to dopamine, histamine, which is your allergic response, noradrenaline. And then on the inhibitory side, your opioid peptides kind of shut everything down, glycine, cannabinoids, serotonin, but some of these can also be excitatory. I'm just keeping it simple here. And then GABA, which is an extremely important inhibitory neuron, very natural. You make it all the time on your own. It's in our sleep gummy for a reason, because it helps balance out the hyperglutamate state. Okay, so remember, I told you to remember voltage gated and threshold. Very important for pain. So the threshold potential is the value, the charge value. So negative 70 millivolts, your resting membrane potential. The threshold whereby it becomes a bit more positive, when it hits a certain number, that's when you're going to get that action potential. If a tissue is excitable, like a lot of glutamate or whatever genetic gene is being transcribed to make it very, very excitable, that threshold will be about 10 to 15 millivolts lower, okay, or less than even the resting membrane potential. So basically that means you're always firing. So if the threshold for an action potential is even lower than the resting membrane potential, you could imagine that that would make a nerve very neuropathic and quite painful. So you have to be able to maintain a normal resting membrane potential, which means you have to have the right number of sodium, chloride, potassium, proteins, an effective cell membrane. All the neurotransmitters need to be in balance, so on and so forth. I just threw this on the side, the Nernst equation, because some of you may be thinking, well, if it's osmosis and there's a lot of particles here and particles there and a lot of charge here and charge there, how does that work out? There's actually a balance. So it's not just the charge on one side and the other, but the number of particles too. It all has to balance, and each molecule has its own number for the Nernst equation, where you can have X amount of charge with this many molecules, and it'll balance with the same thing on the other side. So it's not just the charge, but it's actually the physical molecule, the number of them as well. So quickly to review, we've got a resting membrane potential of negative 70 inside the cell, primarily because of amino acids, right? The sodium channel is shut. The action potential happens. You get enough of a volt to come in that you meet that threshold potential, in this case, negative 55, and it triggers the sodium channels to open. Sodium rushes in. You get an overshoot, hyperpolarization. It becomes very positive in the cell. Then the sodium channels shut. The potassium tries to go rebalance where the sodium was, and then you have the pump that takes sodium and pumps it out over time to build that same resting membrane potential. Now, this sounds like it would take forever, but it takes like milliseconds. And then that's how the body propagates a nerve signal. So here's the meat of how we control pain. So back in 1965, this is how old this is, Melzack and Wall came out with this theory called the gate control theory of pain. And you can imagine that's exactly what it sounds like. If you can control that gate that lets the action potential happen and lets the sodium in or out, then you can control pain. And what they've proposed, which has proved out to be more or less true, and of course there's been some, as in all science, disagreement, alternate theories, criticisms, yada, yada. But really, this is a solid theory that works really well. Non-painful stimuli can close the gates to painful stimuli. So this is like, if you ever get a paper cut or something stings you like a bee, you notice you instinctively grab wherever you were hit and you start pressing it, and it doesn't hurt as much. Well, the reason that's working is because the stimulus from the pressure is overpowering the stimulus from the pain. So the fibers that carry pressure and vibration are thicker, myelinated. They work better than the pain fibers. So if you press something or rub it when it hurts, that's how you can modify the pain signal that your brain's getting. Okay, Dr. Melzak himself said pain is in the brain. So you can completely control pain if you can control how these electrical signals are sent and interpreted and modulated along the transmission line. So pain will start in a receptor, like something you cut, let's say you cut your skin with a piece of paper. There are afferent cells that sense that, oh, something just changed. It's a mechanical movement of the skin cells and membranes ripped apart. They fire, they meet their threshold. Then it transmits to the brain, and the brain interprets that particular signal from that particular receptor in a certain way, and it says, oh, I just got cut, versus, oh, I just got burned, versus, oh, that's really cold. So it all has to do with the type of neurotransmitter, and then the type and the electrical signal, and from which cell it goes to where it goes in the brain, how it's interpreted. So it's pretty magnificent if you think about it, and you can control it just by controlling if you could control the gates. So if you have gate control, then you have pain control. So here's the gate control in action, and these two diagrams sort of show you. So the C fiber is your pain fiber, and then you've got your A beta fiber or alpha, the big fibers that carry like pressure, we'll say. There's an inhibitory interneuron between them, okay? If it's working, then the big fibers from when you press on the cut hit the projection neuron, which is going to transmit it to the brain, as the C fiber does, but they're stronger, so the pain signal doesn't get transmitted. Conversely, if you inhibit the signal from pressing, like if there's an inhibitory neurotransmitter of some sort that allows the excitation of the C fiber to occur, then you do get projection of the pain. So if you can modify the threshold to meet the action potential and or the neurotransmitters at that synaptic cleft, you can modify pain. And so rubbing or pressing an area, that's a simple instinctive thing we all do. A TENS unit, that's how TENS units work. Transcutaneous electrical nerve stimulation. So you put the pads of the TENS unit on and it sends a low voltage current and it changes that threshold. So the threshold cannot be met. You're basically tricking your brain and you don't feel the pain anymore. My favorite way to treat nerve pain nowadays, because it is just so effective, it's almost magical, is a peripheral nerve stimulator. So I'll actually implant these right next to a nerve that I know is hurting. And there's a series of steps we go through to prove that that nerve is a source of pain. Once we prove it, let's say the tibial nerve, the median nerve, perineal nerve, suprascap, whatever peripheral nerve is a true source of pain. If you put this little lead, this little electrical lead right next to the nerve, and then there's this wireless receiver outside that a patient would wear periodically, and it sends a signal to that lead, you can stimulate the fibers and stop the C fibers from sending the pain signal to the brain. And then you can actually use mindfulness. This is how yogis do it. This is how all of the pro athletes now do it, with biofeedback and mindfulness and changing your mindset. And you can literally just tell yourself it doesn't hurt. That's a very simplified way to think about it. But think about this. You know how when a car door slams on a finger, a lot of people don't notice it right away. It doesn't hurt. Well, why is that? Because the shock and the distraction and everything else is overpowering the pain signal. So there's many ways to train the brain. There's cognitive behavioral therapy is massively effective for chronic pain, much more effective than narcotics. But of course, it's a service. It's hard to get coverage. The profit margin's not the same as with drugs, obviously. But don't forget mindfulness training, mindset, cognitive behavioral therapy, all these ways to control how the neurotransmitters work up and down, help you control that gate and give you gate control.